Recording in progress.
Good evening. I'm Professor Sabina Dizdarevic, current president of the British Nuclear Medicine Society and the consultant in nuclear medicine at University Hospital Sussex NHS Foundation Trust, Brighton and Sussex Medical School. It's my pleasure to welcome you to this evening's webinar, the third in our series on multidisciplinary reporting delivered in collaboration with the Society of Radiographers. I would like to take this opportunity to thank you all for attending and to thank our valued sponsors, Siemens, Healthineers, and Novartis for their continued support. Tonight, we'll focus on multidisciplinary DEXA reporting. This session aims to provide an overview of the current DEXA reporting landscape, while also demonstrating and reinforcing the important role of non-medical DEXA reporting in delivering a safe and competent service. DEXA scanning remains an essential tool in the assessment of bone health. It plays a critical role not only in diagnosing osteoporosis, but also in monitoring treatment response and guiding patient management. Osteoporosis is a skeletal disorder characterized by compromised bone strength, predisposing individuals to an increased risk of fracture. It is a significant global health issue, affecting over 200 million people worldwide, particularly postmenopausal women and the elderly. The condition results in millions of fractures each year, contributing to substantial healthcare costs and reduced quality of life for patients. I'm co-chairing this webinar alongside Ms. Hannah Chandler and Dr. Amy Eccles. Hannah joins us in her role as a British Nuclear Medicine Society Scientific and Education Committee Deputy Chair and Educational Co-Lead. Hannah is a nuclear medicine reporting radiographer at London Northwest University Healthcare NHS Trust. She's also senior lecturer on the MSc Nuclear Medicine program at University of the West of England. Dr. Amy Eccles is Honorary Secretary of British Nuclear Medicine Society, Consultant Radionuclear Radiologist, Chair of the Intercollegiate Standing Committee on Nuclear Medicine at Royal College of Physicians, Royal College of Radiologists, and Radionuclide Advisor for the Royal College of Radiologists. She is also a module lead for an advanced multimodality module at multi-professional MSc PGD PG Cert program at Brighton and Sussex Medical School, University of Sussex in Brighton. Without further ado, I would like to invite Hannah Chandler to introduce our first speaker. Hello, Hannah.
Hello, thank you, Sabina, for the lovely introduction, and thank you everybody for attending this webinar. It's going to be a really good one, I think. And I have the absolute pleasure to introduce our first speaker, Andreia Amaro, who is a nuclear medicine chief technologist at Singleton Hospital in Wales. She has extensive experience in nuclear medicine, and her current focus is on DEXA reporting and advanced imaging services within the department. She's really passionate about teamwork and service development, and I'd like to hand over to Andreia now to our first presentation about the landscape of DEXA reporting. So I'll hand over to you now, Andreia.
Thank you, Anna. I'm going to share my slides. There we are. So hi, everyone. Today I'll be discussing the landscape of DEXA reporting and how we can establish a safe, competent, non-medical DEXA service, reporting service. I'll be sharing our local framework, but the aim is to present a model that can be adapted and scaled in line with the national standards. DEXA reporting is not just a task, it's part of a wider workforce transformation. The NHS long-term workforce plan and diagnostic recovery agendas require us to rethink how we use our workforce to meet the ongoing increasing demand by supporting non-medical healthcare professionals to take on advanced practice roles such as reporting. We can improve efficiency and reduce delays in diagnosis. Importantly, under IRMR 2017, clinical evaluation or reporting is recognized as an operator role. This provides us the legal framework for non-medical professionals to contribute safely and effectively to the diagnostic pathway. Alongside this, Professional registration is essential, such as HCPC, RCT, NMC. This ensures that practitioners are working within a regulated framework, are accountable for their practice, and meet recognized standards of competency and conduct. This move towards non-medical reporting is driven by the need for sustainable and resilient services. Our practice should align with the 4 pillars of advanced practice: the clinical practice, leadership, education, and research. By developing advanced practitioners, we are increasing capacity while making our services more resilient for the future. Clear accountability underpins safe reporting. So the health board or employer assumes liability, provided that the reporter operates strictly within authorized standard operating procedures, training, and delegated authority. Each reporter is formally entitled under IRMR. This should be a written formal entitlement with a clearly defined scope of practice, and also should hold professional indemnity through their professional body. For transparency and traceability, every report should have the author's name, role, and registration number. So this should make sure the reporter is doing the reporting safely and supported. Our local framework is built on guidance from national and international bodies, such as the Royal College of Radiologists, the Society and College of Radiographers. They give good references for reporting. And then we use DEXA guidelines, such as the International ISCD, the ANM, the ROS, and NOG. So we use these, we create our framework that reflects shared standard and best practice, so we can deliver a consistent, high-quality service that is safe, robust, and professionally credible. In simple terms, our framework is built around 4 areas. So first, who can train? So we've got strict prerequisites for this. Then how they train, we've got a structured preceptorship and training. Then how reporting is carried out through our standard operating procedures, and how quality is maintained through continuous quality governance. Our aim is to increase workforce efficiency and capacity, eliminate diagnostic delays, and empower our non-medical staff. Before entering training, staff need a strong clinical and technical foundation. So apart from the professional registration that I mentioned, they should have relevant clinical experience, especially in DEXA, as well as some training like the IRMR e-learning training course, and demonstrated competency in DEXA scanning and image quality assessment. These are important skills that as non-medical staff have, because we can assess the technical limitations of a DEXA scan and the image interpretation, and that can directly influence the reporting accuracy. Then in terms of validation, we've got 3 pathways. We offer 3 pathways. And this process ensures that all reporters meet a consistent and safe standard with a target of 90% agreement with a clinical supervisor. The preferred method is the academic pathway, where they complete a university module. The most common module is the DEXA reporting for clinician by Derby University. But there's also one from the University of Suffolk. So ideally, this is the preferred method with a short preceptorship of 100 cases. For those with reporting experience in another area, such as nuclear medicine, a longer preceptorship is required of 400 cases. Sorry. And where academic models are not accessible, we provide a full in-house training program. Although the routes differ, the outcome is the same, a consistent agreement across a broad range of cases before independent practice is allowed. So the preceptorship is where most of the learning happens. During this time, trainees will report cases with a supervisor, discuss more complex cases in detail, and participate in MDT meetings. This structured support allows them to build confidence while maintaining patient safety. Independent reporting only begins once the required level of agreement is consistently achieved and formal sign-off is given. Consistency is essential in reporting. We use standard templates and structures text through context add-ins to ensure that all reports follow a clear and uniform format. I know there's a lot of variability in places for reporting, but the aim is to try to standardize templates. Our approach is also holistic, so we don't focus solely on bone density values, but we also integrate the clinical history, the risk factors, the lifestyle factors from the patient's questionnaire, any previous relevant imaging. So we try to take on an holistic approach. In terms of environment, we are trying to move towards a more digital environment with an integrated digital system. We use Hologic Physicians Viewer software, but again, that depends on what the departments have and what scanner they have. And we also have the support from clinical systems such as PACS, Welsh Clinical Portal, the radiology system. All of that will give us a more comprehensive patient history and imaging history. To enhance reporting, we incorporate advanced additional tools where appropriate. We are lucky to have these more advanced technologies here in our department. So we've got a TBS, so we use whenever we can for assessing the bone microarchitecture. We've got VFA for identifying vertebral fractures. And we've got Frax Plus, which is really useful to adjust the normal Frax for certain risk factors, such as those steroids, number of falls, number of fractures. So it gives us a better, probably 10-year probably a risk fracture. That is really useful to add to the report. So these tools allow us to move beyond basic densitometry and provide a more clinically meaningful assessment, and that's what we want to achieve. Our reporting is guided by evidence-based practice because we are non-medical staff. So we primarily follow national guidelines such as NOG and SIGN. And then we've got specific pathways, specific algorithms for specific conditions such as diabetes, aromatase inhibitors, ADT for cancer, PBC, IBD. All of these require us to be up to date with the most recent guidelines, with the ongoing learning, and to update our SOPs to ensure our practice remains current. So it's good to have staff attending courses because they bring up on all the most recent guidelines for us to use. Then an important part of our reporting is recognizing our clinical boundaries. So if a case falls outside established guidelines, or if there's any uncertainty, we should take this to our MDTs. So we perform We have meetings on a regular basis with osteoporosis specialists. So they provide support with complex cases. We discuss any queries, and then we can improve our standard operating procedures. We also liaise with our radiologists in nuclear medicine. They are always available if we suspect of a vertebral fracture that hasn't been documented, or if we see something on our DEXA image, if we see any artifacts, they are there to just clarify that, and then we can add to the report. This collaborative approach ensures that non-medical reporters are never working in isolation and that patient care remains safe. Finally, we need to know when to escalate this to the local osteoporosis specialist service. So we should have proper criteria for this in our SOP. These are just the main ones from NOG, so they just recommend to escalate that immediately. If these scores are below or equal -3.5, a recent vertebral fracture, or history of 2 or more vertebral fractures, imminent risk of fracture, the presence of multiple clinical risk factors, and if the NOG intervention threshold falls in the consider specialist referral and treatment category. Then, maintaining quality is an ongoing process. We carry out regular audits, including peer review of a sample of reports each month to ensure the standards are maintained. And of course, continuous professional development and reflective practice are also essential components of this role. So we have got our DEXA reporting team meetings every fortnight, where we meet, discuss ideas, people bring on new ideas from courses, and then we improve our SOPs. The benefits of this model are very clear. It reduces reporting pressure on radiologists. It improves turnaround times for patients and supports career development for staff. Overall, it contributes to a more efficient and sustainable service. In summary, this is a safe, effective, and scalable approach to DEXA reporting that supports both workforce development and patient care. Thank you for your time.
Thank you very much, Andreia. That was a fantastic talk and an excellent summary of how you set up your service in Singleton. It's my great pleasure now to introduce a previous colleague, but current colleague as well through BNMS, Marisa de Cruz. She is a nuclear medicine operational superintendent at King's College Hospital with a specialist interest in advanced practice and DEXA reporting. She's actively involved in the development of technologist, radiographer-led reporting pathways and is committed to promoting evidence-based, patient-centred care within nuclear medicine and PET-CT services. Marisa has a particular interest in service innovation and expanding the scope of technologist practice to improve patient outcomes and support sustainable healthcare delivery. It's my pleasure and privilege to hand over to Marisa for her talk on DEXA reporting.
Thank you so much, Amy. I'm sharing my slides now. I'm delighted to be here, and thank you so much for inviting me. So I got invited to talk about experience as a non-radiologist reporting DEXA, including challenges and opportunities. Just a quick outline of what I'm gonna cover, just because I wasn't sure if everyone in the audience has knowledge about DEXA. I'm just introducing a little bit about bone density, and then we will look at the all-person perspective, which Sabina already touched a little bit, Andreia as well. And then I'll go through the role of a non-radiologist reporting DEXA, DEXA reporting benefits, risks and challenges, and this short conclusion. So why DEXA matters? I think Sabina said it all in the beginning as well. It is quite common, osteoporosis as a disease. So 1 in 3 women over 50 will sustain an osteoporotic fracture, and 1 in 5 men over 50 will also sustain an osteoporotic fracture in their lifetime. And these are a bit scary numbers if we look into them. So for DEXA, we focus ourselves mainly T-scores, obviously Z-scores as well, but for the ones that are not familiar with them, I'm just leaving this slide for you to have an idea of what we talk when we say a T-score is under minus 2.5 or is above minus 1.0. And that's how WHO also guides us in the diagnostic of osteoporosis. So at a glance, beyond the standard hip and lumbar spine scans that everyone talks about, there are DEXA-based images addressing specific clinical questions. So we'll have the hip and lumbar spine for standard adult diagnostics, okay, so where we use the T-scores, but then we can also talk about and perform forearms, which are not very useful in most of the conditions, but sometimes is the best we can give for that patient. And they are useful as well for patients with hyperparathyroidism. Then we have total body DEXA that are used in pediatrics and for body composition, for example, for anoretic patients. Then we have VFAs, also mentioned by Andreia, which are essential for fracture detection. We have then all the other geometric metrics that the image will provide, for example, for the hip structural analysis. And we have TBS as well, that most of the services, I would say, for example, an Andreia service is an optimized service in bone health, which is amazing, but most of the services are still trying to implement TBS. In America, for example, is something that is within the DEXA practice. So every time I get invited to talk about this subject, I think it is essential to understand what goes behind the bone density scan. And it is holistic importance of having a DEXA scan. So we need to remind ourselves that osteoporosis is a silent disease, okay? Until the patient fractures, they usually don't know how bad their bone health is. So DEXA will help us to identify systemic skeletal disease before the fracture occurs. It's very focused on prevention, preventative care in preventing fractures, and also risk stratification that supports FRAX integrated 10 years fracture probability assessment. So it is key to remember that DEXA is not just a diagnostic test. It is a preventative intervention that we can help to perform. So whole person impact. When we have a patient in front of us, we don't have only a hip and a spine. We have a history there. So we have someone that is afraid of many things and sometimes of breaking a bone. And DEXA here will have a huge role in reducing the fracture risk, in guiding pharmacological therapy, in maintaining mobility, in informing about falls prevention and rehabilitation strategies. And then psychologically, these also reduce anxiety in our patients. So someone that, for example, his mom fractured the hip and ended up dying because of that, is really concerned about their bone health as well. And sometimes this diagnostic uncertainty, it's essential for them. So we can help to provide this in the bone density scan, to reassure our patients with normal BND, or to reassure them that yes, they need therapy and they can do something to revert their bone health. And obviously, don't forget that patients sometimes get stuck at home because they fracture, they are afraid to fall, and this scan can provide them with enough information for the doctor to help them to go through some therapies and again gain their independence and their social life. And also just mentioning that it is in the NHS, hip fractures are associated with increased 1-year mortality and is actually very heavy in the system. So early identification is paramount. So it's holistic care. We have to have this in mind. The DEXA scan is a gateway to fracture prevention, functional independence, psychological reassurance, and long-term healthy aging that nowadays everyone talks about it. So DEXA goes across several areas. So it's used in early menopause, for example. Some gynecologists will prescribe that, will refer the patients for a DEXA scan when they have early menopause or postmenopausal, or in the endocrine and systemic disease like Cushing's disease or hypothyroidism. It is also essential with some nutritional deficits, for example, severe vitamin D and calcium deficiency or celiac disease, or when patients have, for example, breast cancer and they undergo to aromatase inhibitors and they need a baseline and then follow up in different stages. So this goes across several areas, and that's why MDTs here are so important, and DEXA can play a fantastic role in all these patients' lives as well. So DEXA findings do not exist in isolation. They need directly into a coordinated patient-centered multidisciplinary pathway, informing clinical decisions across specialties. So FLS services rely on timely, accurate DEXA reporting to initiate secondary fracture prevention pathways and reduce costly hospital admissions. So DEXA is again a clinical tool that supports longevity and quality, not simply a bone measurement. And I think this is key when we are reporting DEXA. So radiographers' expanding role. So radiographers, technologists that perform DEXA, we already prepare the patient for the acquisition, we scan, we are able to assess image quality, we recognize any artifacts that can impact the image, and we can then work out the image to suppress the artifact impact. We can then go to the DEXA reporting pathway and structure the report, obviously always following SOPs and guidelines, as Andreia mentioned. So what does the DEXA reporting involve? I always like to include in my own reports a technical review. So this is my baseline when I started doing DEXA. That's how I learned. So I can put in the report all of that. I can talk about the patient positioning, if it was a bit rotated, if the patient for some reason was not comfortable and was challenging to position, if there is any artifact that may impact the results, and also the VFA, which at the moment, for example, I'm not doing, but lots of hospitals have it as a standard of practice as well. And then in stage 2 of the report, it comes the clinical interpretation, where I then use the T-scores to compare young adults reference population based on the WHO diagnostic classification. And obviously, it is important to use all these guidelines and look at the patient's age, look at ethnicity, and know how to incorporate them in the report, and look at the questionnaire that the patient provides, not only looking in isolation to the numbers. So why specialize in DEXA reporting? So I truly believe, and that's why I like to use the Ikigai, the Japanese concept of reason for being, that you need to like what you do. So you need to find purpose on that. So you are skilled for it, you love it, you understand why you are providing these results to the patient. It's needed on the system. DEXA reporting is needed. So at the moment we have lots of demand and probably not many people reporting DEXA. And what patients need? So they need a timely, accurate reporting within the guidelines, and they need that to then go to their consultant and trigger some sort of therapy. So it's important to understand that reporting matters, and that's why I put these numbers together here. And it's also costly on our system, and financially, I'm sure everyone talked about and or heard about financial deficits within the NHS nowadays. And it is important to keep ourselves on our KPIs, so reporting DEXA can help with that as well. So, as a DEXA reporter, we can do independent reporting, training radiographers, issue a DEXA report, reducing the radiologist dependency and improving turnaround times for patients and referrers, which is super valued. And it's also a way for us to advance in our career. It's another skill that should be valued. Obviously, we need to follow strict protocols, and it is important, like Andreia said, that we do this. And we need to understand when to use escalation pathways as well. So it is important to have a robust structure in place, which is one of the challenges. So clinical governance, training and competencies. So like Andreia mentioned, we had the Derby University, and we had the ROS as well that used to have some sort of training. Obviously, these trainings sometimes don't happen every year. They are not available for everyone, because sometimes you need to do a IELTS, you need to do the RCT first, which delays the pathway as well. So then we can do in-house trainings, but also it depends if we actually have enough staff to deliver that training. There's lack of supporting groups, and here I talk about groups that can do some peer review, for example, or we can discuss cases. Structured audit programs as well. So ROS did launch audit program that I'm using at the moment, but we don't really have sometimes the time and the support to do this. Some MDT collaborations, which is not always possible, and clear referral pathways. So within the NHS, we need to understand who needs to refer patients to us, and sometimes external referrals cannot refer patients to us because service level agreements are not in place, and there's other bureaucracy associated. So incidental findings can also be one of the challenges, where we would need a radiologist, or would be good to have a radiologist to discuss some cases. VFA, vertebral fractures identified with VFAs can also be one of the challenges, where we need a bit more training. That, for example, the Derby training does not provide any learning on this. Then these boundaries that Andreia was talking, clinical, medical, legal responsibility, the lack of peer support, it's still an undermined area where you can see, for example, nuclear medicine, cardiology is an advanced practice route. DEXA reporting is still a bit undermined. There's no protected time sometimes on our job plan. And like I was saying, the advanced practice is still not seen as another career option. So there's challenges interpreting lumbar spine and T-score as well. And here is where we could have, and it would be beneficial to have some reporting groups where we could discuss the cases where BMD is falsely elevated or falsely reduced, or there is some sort of spine-hip discrepancy. So obviously for new radiographers reporting, it is important to have some sort of reassurance and support in how they can improve their way of reporting and how they can analyze the images. And then some challenges interpreting low Z scores as well. So again, like this could be essential to provide the best care and the best report possible for the patients. And for example, which is quite challenging for GPs when they send patients to us, and we know for them we have to have a structured report. It's completely different of sending a report for a fracture liaison clinic where they know what they are looking at, to a GP where they actually need a bit more guidance. So we need to be more thorough with that. And then obviously some challenges like position errors, where we need to reanalyze the image, mislabeled vertebra, incorrect disc space placement. So all these technical issues that we also need to look at, and we will need to go back to whoever did the image for them to reprocess and get it with the right analysis. Obviously, we always have the non-clinical guidelines to follow, and that's where our practice is based mostly. And then I just included some illustrative cases. So, for example, for you to understand how broad DEXA scan can go. So, for example, this patient, the breast cancer patient, over 50 years old woman, and she basically the clinical indication was on aromatase inhibitor, started early 2025 and never had a baseline scan. So the patient came to us and we literally look at the T-score and the Z-scores, and this patient had normal bone density. Then case 2, for example, where we can see this patient had a prostate cancer, and in prostate cancer we have to have a look at other images as well, because as you can see in the report I placed there, the PSMA shows that there is metastatic disease involving the ischem as well, the right inferior pubic ramus, and sometimes these areas overlap with areas that we analyze in bone density, and then this can trigger an increase on the BMD as well, and we have to be mindful of that when issuing a report. And then in this case again, I just put one of the reports where I did a technical analysis. I didn't put the images so it's not too overcrowded in the slide, but basically a technical analysis explaining why L3 and L4 were excluded, and then a conclusion, and then a follow-up recommendation within the guideline of 2 years intervals wish list on this type of medication. Then I'm just leaving here radiographer reported checklist, which I think it's important to go through when we are reporting, and is part of the governance. And then as a conclusion, the value of radiographer DEXA reporting, it's DEXA reporting by non-radiologist is safe, effective, essential, because it does help radiologists as well. It does help the backlog and our patients. Radiographers or technologists bring unique strengths in acquisition and interpretation. So we know what we do when we are acquiring, so it's easy for us as well sometimes, especially if we are acquiring and reporting, because we know exactly what was happening with the patient. We can issue high quality reporting that impacts directly fracture prevention, and this role supports bone patient outcomes and service sustainability. In the future, as opportunities, I think we could expand the radiographer-led reporting services, integrate with FLS and preventative healthcare models, adopt some tools like the TBS and maybe AI-assisted reporting as well. Development of structured national training pathways, I think we will need to look into this. VFA expansion, integrated fracture liaison service within the DEXA department as well. Integration of, the TBS already said, and then look at the career progression as well. As a final take-home message, DEXA, just remember that DEXA is not just a scan, it is a clinical decision tool. Accurate reporting requires both technical expertise and clinical judgment. Radiographers or technologists are central to deliver high-quality DEXA services, and investing in this role means investing in patient outcomes as well. Thank you so much.
Thank you. Thank you so much, Andreia and Marisa. That was brilliant. And we have a lot of questions already from the audience. So Andreia did answer on some of them, but I might want to, and audience, I'm sure, wanted to see and hear your views, Marisa, as well. So the first question was on the use of AI tools in DEXA reporting. So it's been already answered by Andreia, but I think if you could just briefly, explain your views, and then Marisa as well, please.
Thank you. So we do not currently use AI tools in our department. We are very interested if that will help to speed up our reports, because at the moment, because we do a very comprehensive report and it takes us a bit of time. So if that helps us to streamline and potentially speed up the reporting process, that would be great. If anyone wants to share any ideas.
Marisa?
Yes, so in my perspective as well, we don't have anything in place, and I'm not aware of any service that actually use anything for DEXA reporting. But I do think, and that's why I included it on my slides, it's a future key element, because it will help. So the backlog at the moment and the demand for DEXA is really high, and we need to provide quicker results, but at the same time we need to make sure they are personalized to the patient, they are providing what the clinician also needs. So AI is essential, but I don't think it will replace the reporter role at all. We will be there to validate the AI tool as well and to add any personalized information that is needed.
Yeah, as you just shown in your examples, is that there are a lot of personalized information that are needed to synthesize the knowledge into the report. And we could say that we use augmented reporting for a long time, because you get just like produced images with the T-scores, Z-scores, but not validated if they are really correct or not. So clearly there's something, a space to be watched, and otherwise, what I say, we're not going to be replaced by AI, but we will be replaced by people who are not using AI. So it's inevitable, is it, progress? Thank you. So I think next question maybe from Hannah, from the our attendees.
Yep, absolutely. And again, I think it's been answered in the chat, but it'd be good to hear both of your views as well. So there's a question here that says, can you advise what approach to take for trusts that do not have on-site radiologist, rheumatologist help or guidance for non-medical reporters? And I'm sure you've both had experiences where this has happened. And Andreia, did you want to go first?
Yeah, so we've got regular MDT meetings with off-site osteoporosis specialists, so they are from a different trust. We scan DEXA scans for them, and they participate in this. They are always available every fortnight. We meet with them, so we are able to have these meetings even though not on site, online. It works very well. We discuss all the cases. We have time to answer any queries and then apply that to our SOPs. So it's been working really well. In terms of radiologists, we are lucky because this is in our nuclear medicine department. So we've got our reporting radiologists always there. So we can just go and show a VFA or ask to check a CT scan. And that's we are really lucky to have that available.
It's really great to hear. It's great to have the support around you, especially when you're with training as well. Marisa, did you have anything to add? Maybe some experiences?
Well, yeah, we're quite the opposite. So we don't have MDTs happening. And that's why it became one of my limitations and challenges. We do have some radiologists around, but our radiologists don't really focus themselves on DEXA reporting. And it's not their priority, it's not their interest as well. So we don't have anyone to go to and discuss sometimes some sort of questions that arise while we are reporting. So what I tend to do is to have all together, and then when I find one of the radiologists that report DEXA, I go to them like very quickly, can we just go through these cases? We do have, and we established now a very good relationship with our FLS clinic as well. But it's still, like I was saying, a part of FLS and cystic fibrosis clinic, it's still very difficult to reach the people and to gather their interest for this area. I guess I don't blame them. There's so many things going on. That's why I was saying this is a little bit of undermined area. But it is on our pipeline as well to kind of create a meeting with rheumatology, at least, every 2 months or so, where we can pile some cases and discuss them as well.
Great, thank you, Marisa. I think I'm going to hand over to Amy for the next question.
Thanks, Hannah. And we've got some excellent chats going on, which is brilliant, and linking people from all over the country and beyond about different communities that can get together and sort of talk about some of the things that have been asked about. So one of the questions is actually fairly technical. So is it whether or not we only use the Z-score for forearm in primary hyperparathyroid patients? Now, this might open up a can of worms depending on who does what. But Andreia, what's your practice in terms of primary hyperparathyroidism and the use of forearm?
Yeah, that's right. We always scan the forearm if there's primary hyperparathyroidism, or if that's the only site available, or if they are over the weight limit of the scanner. So as a last resource, we use the T-scores of the 1/3 distal radius.
Yeah. So I think we all use the forearm, as you said, Marisa, in your talk as well, for primary hyperparathyroidism. Personally, I use both the T-score and the Z-score in my reports. Ultimately, I think that might be the role of the endocrinologist or the surgeon at the other end of the request to make a decision about which number that they're going to use as a guide for their clinical impact and change of management for the patient. But it's one more number. I don't think it's going to make a huge difference to the length of your reports, and it's probably better to have more in. But Marisa, you also talked about using forearm maybe in patients where you might overestimate bone density in other areas, so maybe thinking about prostate, etc.
Exactly, yeah. For example, prostate cancer is a brilliant example because when we can quickly access to a CT or a PET and we see there's some mets in other areas, I will add then the forearm to give us a little bit more information. Like Andres is saying, sometimes it is the only site we can provide and the patient is there. That's what we can do. For hyperparathyroidism, we also provide T-scores and Z-scores. But again, usually doctors that refer a patient with hyperparathyroidism, they know exactly what they're looking at. So it's a bit easier as well. And we can provide both results and they can evaluate them as well.
Yeah.
Should I say that, like traditionally, Z-score is used for patients that are under 50 for all sites, and then there was a discussion about should we actually use for some patients that are around 40 to 50 or 30 to 50 once when you reach the like a peak bone mass. So probably in reports we are led by that sort of thresholds as well for forearm as well for the other sites as well. But as you said, it's like personalized as well, putting into like, clinical indications together and really forming and your final clinical report rather than technical report is what matters at the end. So, yeah. I think there, as Amy said, there are quite a lot of questions, and we have people who are also active. Jane Trelkeld saying that endocrinology would be another option. So, I mean, this is probably what we are discussing as well. And some more questions about governance around the professional indemnity. So particularly for staff groups who are not on statutory register, for example, technologists. So maybe Andreia and then Marisa or maybe even Hannah. Do you have any governance about staff groups who are not on statutory register, such as technologists? Or would it apply the same as for radiographers in a way for in-house training?
Or is it required to have a professional registration to be able to follow to become a reporter? Yeah.
Marisa?
On our side, so like I was saying, the Derby course will have RCT as one of the criteria to enter. So we will do in-house training for non-RCT registered because of the demand we have at the moment, and also because it's not a mandatory registration yet, but we do advise them to pursue the registration alongside.
Yeah, and I think also just to mention and keep it fair, there I know Andreia mentioned it, that the Suffolk University does have a DEXA reporting course as well. So yes, we're talking about Derby, but there are other courses out there. And hopefully through those courses and some of the other resources that you've talked about, that might answer Rinku's question about guidelines or templates for examples of SOPs or writing DEXA reports. So again, maybe that's something that Marisa, you can touch on. Where did you generate your standard report from?
So in terms of training, so that's why I'm more focusing on the Derby one. So that's my experience. That's the one I know better. Then obviously I did all the 100 cases in-house, and we are constantly within our DEXA group updating our template. There is a very good meeting in London, DEXport, which is a meeting in Bond Density, which we tend to go, and that's where we also gather more information to then shape our templates and change our reports as much as we can.
Andreia, do you have anything to add for that one?
We've got, in terms of reporting, we've got a standard template that we get from a physician's viewer that belongs to Hologic. So we get as much automatic data coming across to our report as possible, and then we use kind of context where we just add up through the reporting structure to minimize any typos and speed up the reporting process. In terms of training, in our team we are about 10 non-medical staff, and we try to have somebody every year on the training like Derby, so they always bring up updates and new guidelines for us to discuss and improve. So we always have a fresh mind in the team to keep up with all the updates.
Excellent. Can I just also say that Jane mentioned that their trust has approval via Advance in Practice Board, which means that we are then covered by the trust insurance. So that's quite good. So I don't know what trust is that, Jane, but would be quite good to maybe have some sort of the business case, or how do you reach to those approvals that we are not reinventing the wheel. Yeah.
Suppose just, sorry there, Sabina, just to add there, talking about kind of RCT registration and how we get around that. I suppose this goes back to the scope of practice that is agreed locally within the department. And of course, if you are having a need and there is a real shortage and you're really struggling, that may be something that is at a local discussion, is covered locally. And I can see Andreia and Marisa nodding there. So just another thing to bear in mind about the scope of practice, and that will be signed off at a local level, although based on those national guidance.
Okay, and then we have a question. Is there any guidelines or template or example SOPs to support writing up a DEXA reporting SOP?
The first template we designed was based on the ROS template, which should be still online, and provides lots of information. Then obviously depends on the questionnaire. Everyone can use a different questionnaire in the department as well. What we did in our case, we had templates set for several scenarios, for Z scores and T scores. And then some people, like for example myself, I always give some lifestyle advice as well, if appropriate, according to the questionnaire. But our first go-to was the ROS guidance.
I could see one question in the chat, which is the current best practice to report L1 to L4 or L2 to L4? From Joshua Franklin.
So I would say, and Andrea, you can go after me as well, but I would say L1-12-4. I know a few years back, some hospitals were reporting L2-12-4, and I still have that because I have to exclude L1 when I have these patients coming again for a follow-up, but at the moment, L1-12-4.
Yeah.
The same.
Okay, that's the guidelines. So unless L1 has a fracture or metastasis, when you have to exclude it, yeah. So, okay, so just like with regards to question about AI and tools like TBS, how do you see the role of DEXA report in general, medical or non-medical, over the next 5 to 10 years? Marisa, Andrea?
Obviously, I would like to see these becoming advanced practice for non-radiologist staff, so technologists, radiographers. I think in terms of demand, it will help a lot. I think in terms of clinicians, I know you guys also have a lot on where you can focus, and we can all work together, which I think would be brilliant. And I think that's how I see it in 5-10 years, to have more of a reporting group where we can all give our input. And obviously AI will have a role, but like I was saying, the role of AI will be to support us to meet the demand and not to replace it all.
Yeah, I think there's room for everyone, and we definitely have got the foundation skills and the guidance available to create a proper, robust framework to report nicely, as long as we collaborate, like you say, in a multidisciplinary team. And this will hopefully help release the doctors from doing this task and dedicate on other tasks.
Thank you. So I think we have maybe one more comment about osteoporosis conference being run by the Endocrine Society now and is in Manchester, September 9th and 10th. So I also want to mention about our webinar that we did on osteoporosis last year, which was a half-day webinar, which was very useful. So please, for the BNMS members, you can join and ask Caroline to release that link for you if you can't find it on the BNMS website, which incorporated a lot of clinical indications and the clinical aspects on the treatment. So if you're interested in osteoporosis, I highly recommend that webinar too, and clearly this one as well. Hannah and Amy, any final comments or questions before we close this webinar?
Just thank you very much to our speakers, and to reiterate what Dom had written at the beginning, thank you very much to our sponsors. This has been a really, really fabulous webinar and has generated a lot of conversation and hopefully has brought the community together, which is always what the BNMS are trying to do, and supports all of our multi-professional groups to ultimately improve patient outcomes. So I think that's been a really, really tick. We've done that tonight. So thank you very much.
Said it better myself, Amy. Thank you to everyone as well watching and taking the time out of their busy days. And I'm sure if there are any questions that couldn't be answered in this webinar, then I'm sure you can reach out and somebody will be able to answer those for you. So thank you again.
Thank you all, and please look out for our upcoming webinars over the summer. We promised exciting program. Thank you. Thanks all.
Thank
Bye.
you, everybody. Bye-bye.
Bye-bye.